Hello, good afternoon, everybody. Thank you for inviting me to be with you today. I'm going to address the assessment of twin pregnancies, what we need to do with them, and how we're going to monitor them. So we're going to talk about chorionicity and the implications of chorionicity, how we're going to screen for chromosomal abnormalities for management of twins. And we are going to talk about some of the interventions we do in twin pregnancies. As well, we're going to be talking about the complications of monochorionic twins. And as we all know, we have two types of twins. We have twins that happen due to having more than one egg produced in each month, because we know that humans have this very unique feature of follicular dominance, where only one dominant follicle continues every month. And breaking this dominance will produce more than one egg, so having more chances of producing more than one embryo for implantation. Obviously, we do increase that risk for producing twin pregnancies by induction of ovulation and by the procedures we do for in cases of assisted reproduction techniques. So if we look at the epidemiology of twins, we have 70% of twins coming from two fetuses, what we call dizygotic, and about 30% of twins happening because of one fetus splitting early in pregnancies. So by far, the commonest type of twins is the dizygotic twins. When we look into twin pregnancies in another way, where we know that we either have the twins that already originated from fetuses and two embryos start, or we have one fetus split. Yes, we need to mute. Can all the participants who are joining us, can you please mute your mics? So can you mute them all, because some of them are talking, please. No, we need to mute the participants. Mute all. Mute all. That's it. So as we talked about before, we know we have those types of twins that came from two separate fetuses that implanted due to having more than one dominant follicle coming out. And as you say, this is increased by induction of ovulation and any ways of assisted reproduction, or when we implant more than one embryo, like what we do in cases of assisted reproduction technologies. And then we have a type of twins where we have one fetus that splits. And according to the time of splitting in days following fertilization, this determines the chorionicity of those twins. So if the fetus is split within the first 3 days following fertilization, we end up having enough time for the fetuses to split their placentas, to split their amniotic sacs, and to obviously have two separate bodies. So we have what we call dichorionic, diamniotic twins. Chorion for us means placenta. So if you have dichorionic, which means two placentas. And the reason why we're addressing it as being two placentas, because we know that fetuses with one placenta can share circulation. But if you have two separate placentas, then they are not likely to share circulation. If the splitting of the fetuses happen between day 3 and day 9 following fertilization, then there's not enough time for them to split their placentas. So they become monochorionic. So they have one placenta, but they have time to split their amniotic sacs. So they have two sacs. So they are monochorionic, diamniotic, and obviously their bodies are separate. A rare type happens when you have splitting happening between day 9 and day 12 following fertilization. And in that context, you don't have enough time for splitting of the placenta. So they have one placenta, monochorionic, and they do not have enough time to split their amniotic sacs. So they have one amniotic sac. So they are monochorionic and monoamniotic. But this is quite a rare type of monochorionic twins. We hardly see much of those. And then we have the late cases of splitting, when the splitting happens after day 12 following fertilization, and those fetuses do not have time to split. So they have one placenta, monochorionic, one amniotic sac, monoamniotic, and as well, their bodies got stuck together, what we call conjoined twins. And when we want to address that, we want to make a clear definition between those types of twins early into the pregnancy. So when we see them early in pregnancy at about, let's say, anything from 6 up to about 8 to 9 weeks, in cases of dichorionic twins, you'll find that you have two completely separate fetuses and two separate bodies, and there is quite a bit of tissue separating between the gestational sacs with each fetus inside. But in cases of monochorionic twins, it will seem to you as at first it seems like it's a one sac, and you will actually have to search clearly until you find the differentiating line between the two gestational sacs, and I highlighted it here in black so that you can actually notice it. At later gestation, it's a bit easier because either you have two separate placentas, one anterior and one posterior, for instance, and if you have two separate placentas, then you know that you have dichorionic twins. Or you have one placenta, and when you have one placenta, you actually have to look at the dividing membrane between the two twins. In cases of dichorionic twins, you will have a multi-layer line separating between them with a tongue of placenta going inside the dividing membrane, what we call the lambda sign. But in monochorionic diamniotic twins, the dividing membrane is actually thin, single layer, and it joins the placenta at a 90 degrees angle, what we call T sign. So why is it too important for us to have that understanding? The understanding of that explains the risk of complications that happen between those twins. Because we know that cases of dichorionic twins have, in comparison to monochorionic twins, have lower risks of miscarriage. So we have a 10% risk of miscarriage after 11 weeks, because we know that the risk of miscarriage is quite high in fetuses before 11 to 12 weeks generally. But after 12 weeks, this risk reduces to about 1%. So in dichorionic twins, simply because you have two fetuses, your risk of miscarriage after 11 weeks is 2% because you're doubling the factor of being one. But in comparison to monochorionic twins, the risk of miscarriage is about 10%. The risk of perinatal death is higher, so it's 4% in monochorionic twins in comparison to 2% in dichorionic twins. The risk of growth retardation is 1.5 times. The risk of preterm birth is double, and the risk of major defects is higher. This is how they look like. Even when we do 3D ultrasound, you can see here clearly the lambda sign separating the dichorionic twins and the very thin membrane, dividing membrane in cases of monochorionic twins. So why do we have this condition? We have a condition called twin-to-twin transfusion syndrome, and twin-to-twin transfusion syndrome is a unique condition that happens only in cases of monochorionic twins, where they have vascular communication across the surface of the placenta. And when you have this vascular communication, they end up sharing their circulations. So one of them might give a significant proportion of its blood or its circulation to the other fetus. So you have one fetus being a donor and another fetus being a recipient. The donor fetus will be giving a proportion of its blood to the recipient. The donor fetus would lose a significant proportion of its circulation, so it will have a restricted circulation, and it will send less blood to its kidneys, so it will produce less amniotic fluid, and when it has a restricted circulation, it will not grow enough, so it will undergo growth retardation. On the contrary, the fetus that has a higher fraction of the circulation would receive more blood than it usually should. So it will send more blood to its kidneys and it will produce higher volumes of amniotic fluid. So it will cause polyhydramnios. Its size will be slightly bigger. And as well as you overload its circulation, then it's likely to develop features of heart failure. So when we want to check for this difficult condition, we can check for it at different stages of the pregnancy. The first stage is checking for it early in pregnancy, at about 12 to 14 weeks when we're doing the first trimester scan. And in that case, we find that the fetuses, although they should be identical, so they should be carrying the same size, they should be carrying the same features, they should be carrying the same markers for chromosomal abnormalities like nuchal translucency, because they came from a single fetus. So you will find that there is discrepancy in size and discrepancy in the amount of amniotic, in the amount of the nuchal fluid thickness, or what we call the nuchal translucency at that stage. As time goes on, there will be a discrepancy in the amount of amniotic fluid. So instead of having the dividing membrane between them freely floating, you will find that there is what we call membrane enfolding, where there is discrepancy. This sac has less amniotic fluid, this sac has more. So you'll find that the membrane is pushed to one side. And then we develop the very late condition when we have severe twin-to-twin transfusion syndrome. So you'll find that we have a donor twin that is stuck to one side of the uterus by the amniotic membrane because it does not have much fluid around it. It shows features of IUGR, so it's small in size in comparison to a fetus that has a polyhydramnios, as you can see here. So you have a donor twin that has a restricted amount of fluid, restricted size, and the amniotic membrane will surround it, so it will stick it to one side of the uterus, in comparison to a recipient twin, which has an obvious bladder, polyhydramnios, and a slightly bigger size in comparison to the donor twin. Why is this condition so important? actually, this is the essence of the complications of monochorionic twins, because you have this difference or communication and circulation that actually what causes all the pitfalls we talked about and the risk of complications we talked about in cases of monochorionic twins, because this is what increases the risk of miscarriage, this is what increases the risk of preterm birth, and this is what increases the risk for sudden death. Is there anything that we can do about it? Well, the best option for us would be to go in with a fine scope, what we call a fetoscope, which is a specifically designed scope to separate between them. We go through the sac of the polyhydramnios, so we go through the sac where we have a lot of fluid. This is we going through the scope here. We can see this is the dividing membrane. This is the fetus that has the oligohydramnios. We're now in the sac of the polyhydramnios, and we look under the dividing membrane into those communicating vessels, and using Nd:YAG laser fiber, we actually cauterize this vascular communication between the fetuses, aiming to try and separate the circulations again to be a separate circulation. So as you can see here, you can see the communicating vessels in those types of twins. And what we're doing now is actually burning those vessels or diatherming those vessels using Nd:YAG laser to try and stop this vascular communication between those types of twins. Okay. The other question we have in twins is the risk for preterm birth. And we know that one of the ways we can screen for preterm birth is actually measuring the cervix by doing transvaginal ultrasound. Obviously, transabdominal is not as accurate. So if we think that the cervix is short, because actually the main function of the cervix is assessed by its length. So if you have a cervix that is less than 2.5 centimeters in length, or it's showing funneling, as you can see here, this is the cervix that is actually, the remaining part of it is short, and it's showing funneling as well, then this fetus, this patient is at risk of delivering prematurely. The question we have is what we can do about it. We have actually, research has shown significant reduction in the risk of preterm birth in singleton pregnancies that have a short cervix by administering vaginal progesterone. However, in cases of twin pregnancies, this has not been proven to be as successful as it does in singleton pregnancies. So what about cerclage? Well, we know that the risk of preterm birth or the increased risk of preterm birth generally in twins is caused mainly by over-distension of the uterus, by the fact that the mother is carrying, or the uterus is carrying, double what it should be carrying in the context or in comparison to mothers who are carrying a singleton fetus. So vaginal progesterone did not prove to be as effective or as successful in multiple pregnancies, particularly in twins. What about even given it prophylactically? And this is one of the researches we've published actually in my unit, when we gave prophylactic progesterone, and even in women with twin pregnancies, and we randomized them even to placebo and vaginal progesterone in women who had a normal cervical length, and it did not show any difference in the outcomes, whether in the neonatal outcomes, the risk of preterm birth, or the risk of neonatal complications. So twin pregnancies, the risk of preterm birth, particularly in dichorionic twins, is mainly caused by over-distension, and there isn't a lot we can do about it, and we really need to be cautious about intervention. And then the most important part from my perspective is tocolytics. When we address singleton pregnancies, the Royal College of Obstetrics and Gynae has actually made a clear statement saying that you should only consider tocolytics for a 48 hours interval to allow for giving corticosteroids and in utero transfer of twins from a peripheral unit to a central unit where you have the facilities to care for neonatal for preterm birth. The question we really need to appreciate is, we understand that in singleton pregnancies, we have maternal changes in the circulation that affects the mother's health. And this change in the circulation is mainly caused by the fact that the mother has to increase her heart rate, it has to increase her respiratory rate, it has to increase her stroke volume by about 15%, and as well that it increased its intravascular volume by 40%. So instead of having 5 liters of intravascular volume, the mother would adapt about 1.8 liters of plasma and about 400 mils of packed RBCs. And this is actually more demonstrable in cases of twin pregnancies. So in twin pregnancies, you have more increase in the maternal circulation and more increase in the cardiac functions, which means the mother is actually doing more effort in twin pregnancies on her circulation in comparison to singletons. And for that, as we know as well that the risk of preterm birth is mainly caused by over-distension, the use of tocolytics in twins should not be something that we should consider easily, simply because of the risk of complications. As well, when we consider tocolytics in singleton pregnancies, the consideration was for giving calcium channel blockers or atosipan, which is the synthesinone antagonist, and not giving beta-2 beta-2 stimulants, simply because they do increase the heart rate, they do increase the load on the mother's heart, and they were a cause for maternal mortalities. So I would be quite cautious in considering tocolytics generally in twins, and I would not consider beta-2 stimulants at all in twins, and even not the other preparations, simply because the efficacy of them is quite low and the risk of complications to the mother are quite high. What about the everyday care for the twins? Well, if you're going to be measuring them and monitoring them, then it's actually quite simple. First of all, you need to decide, are they monochorionics or dichorionics? If they are dichorionic twins, then we'll be assessing each fetus individually. So we'll be measuring them individually, we'll be doing the risks for screening for chromosome abnormalities individually, we'll be monitoring their growth individually, and we'll be assessing for risk for major defects individually. When they're monochorionic twins, we know that they're coming from the same fetus, so we know that they carry the same genetic material. So if we go through the first semester, if we're screening for chromosome abnormalities, then we'll be measuring the nuchal translucency. It has been shown to be an effective measure for screening for chromosome abnormalities in singletons, as well as in cases of twins. And as we showed as well, it has one more advantage in that in cases of monochorionic twins, if you find a discrepancy in size and a discrepancy in nuchal translucency, you will be suspecting that this case is likely to progress to twin-to-twin transfusions. As well, the other markers we use is the presence and the absence of nasal bone. Fetuses should have a clear nasal bone that's in continuation with the frontal bone in comparison to the case of absent nasal bone. We know that in our dark African population, we have a 1% of the cases who will have normal absent nasal bone, but only 1%. But in 99% of the cases, they should have a good visualized nasal bone. As well, we know that in the fetal circulation, we have a shunt, what's called ductus venosus, which takes the blood coming back from the umbilical vein and shunting it directly to the heart. And because it's a vein that shunts a significant proportion of the blood and is directly connected to the heart, it reflects actually the cardiac functions. So this is used as one of the screening tests for chromosome abnormalities and another screening test for cardiac functions. And we know that it can pick up about 60% or more of cases of chromosome abnormalities, and as well it can pick up about 90% of cases of major cardiac defects if it's abnormal in the first trimester, showing absent diastolic flow, what we call absent A wave, as you can see here. Again, we as well check for the final marker, which is the flow across the valves of the mother's heart, of the fetus's heart. So we go through screening for tricuspid valve regurgitation, and incompetent tricuspid valves do increase the risk for chromosome abnormalities. They do increase the risk for major cardiac defects by about 50%, and as well they work well whether you use them in singletons as well as using them in multiple pregnancies, particularly in twins. What about using serum biochemistry? I would be quite cautious about using serum biochemistry. They need really good auditing labs. They need to be using specific formulas, and as well, the interpretation of them carries a bit of a concern. Can we use free fetal DNA? Well, you can, but when it comes back saying it's abnormal, you really need to think of ultrasound to consider, so which fetus is the abnormal one? Because if it's a monochronic twins, then they'll definitely both be abnormal. If the test comes back positive and we'll be considering taking a sample from any of them, it will give you a result. If they are dichronic twins, then it's just telling you that there is a fetus that's abnormal and you have to go by ultrasound and try to decide which one is the abnormal. So can we do something about screening and diagnosing chromosome abnormalities in the first trimester? If we're doing all those tests for screening, then we definitely should be offering a test for firm diagnosis. And we have two options. The first option is taking a sample from the placenta at after 11 weeks of gestation, what we call chorionic villus sampling. And for that, we can diagnose chromosome abnormalities, or if we are screening or testing for any of the known inherited genetic disorders, let's say thalassemias, single gene disorders, Duchenne dystrophy, spinal muscle atrophy, any of those, we can do that by taking a sample from the placenta after 11 weeks. And if the patient presents a bit later in gestation, then we can take a sample from the amniotic fluid, what you call amniocentesis. But we can't do that before 15 weeks. And that's what actually the Royal College have just made a new declaration this morning when they actually updated their guidelines, saying that the risk of miscarriage in singletons is about 0.5% in expert hands, whether you use amniocentesis or chorionic villus sampling. You should not be considering chorionic villus sampling before 11 weeks, and you should not be considering amniocentesis before 16 weeks. So how do we do it? We go in with a needle, we take a sample from the placenta. You really need to decide what you're facing, because if you're facing a monochorionic twins, then you can actually just go in and take a sample from any part of the placenta, because it will reflect both babies, because they come from the same genetic material. Do we agree on that? But if you face dichorionic twins, then you really have to go and sample each part of the placenta, and it can be tricky, because if you have two placentas, you'll have to insert the needle twice to take one from the anterior and one from the posterior placenta. If you have a single placenta, then you have to use a specific needle where you have to insert the needle as a guide and go with a stiletto and take a sample from the peripheral part of the placenta, and then go back and take a sample from the proximal part of the other placenta, aiming to get a sample from each part. But we have to appreciate that there is a small proportion of the dichorionic twins, if you remember at the start, that came from one fetus that split during the first 3 days. You remember that when we started our introduction. So there might be a chance that the results come back saying that the samples are identical. And in that context, I would maybe consider taking an amniocentesis sample, because I will then puncture each sac individually and take a sample from each sac individually by crossing the amniotic membrane, taking a sample from each sac as I can see it. And by that, I would confirm that there is no way I would have contaminated the samples together. And then we end up by conjoined twins, and conjoined twins for us is such a difficult condition. As we said, it's a form of monochorionic twin. It's a form of its complications. Usually they join each other at the region of the chest and abdomen. So rarely they join each other at the regions of the heads or at the regions of the sacrums. But conjoined twins, it's such a difficult condition, because if you see them as early in pregnancy as possible, please consider termination instantly, because as they grow, they become very difficult to deliver. And sometimes when we face cases in the second trimester, it's really even difficult to deliver them vaginally. And if they come in the third trimester, then it's a very difficult cesarean section to do, because you have to get double the size from the same incision, which means you have to actually enlarge your incision, like you have to do an upper segment cesarean section in comparison to doing a lower segment cesarean section. So are they easy to inspect and see? Yes, definitely they are. As you can see here, those are conjoined twins. They are joined together at the level of the chest and abdomen, and you can see them even in the first trimester. So if you see them, you record what you've done, you show it to your trainees, but I would be considering termination instantly on the day. And one final complication of monochorionic twins, what's called TRAP, which is a form of having a fetus, as you can see here, that has an amorphous tissue of body that starts to develop into features of a baby, but it does not have a heart. And it relies on its circulation coming from its monochorionic other fetus. So this is a monochorionic pair. This is the fetus that does not have a heart, and this is the fetus that has the circulation. So you'll find that it does not carry a heart, but it takes circulation through a cord that takes blood from the other fetus. So one fetus is doing the job of the cardiac functions of two, is pumping blood to itself, and is pumping blood to its twin reversed arterial perfusion sequence, which is called the TRAP other fetus. Should we do anything about it? In most instances, we just follow up the normal fetus to make sure that it does not develop features of heart failure and hydrops. Or if we find that they actually have shown features of hydrops, then we can do ligation of the cord of the TRAP fetus, the fetus that does not have a heart, to reduce the cardiac function load on the normal fetus. Okay, I guess I'll stop at this point, and if you have any questions, by all means, I can answer them. Any questions? So we'll be doing a demo on the Volocin Swift, and we'll see.
Anyone have a question for the participation from online? Okay, So what we are doing now, we're connecting the machines to do live demo or live practice on the patients. So 5 minutes, and we're connecting the machine or connecting the image to the online.
Are you on? Okay, so we're going to be doing a live demo scan on this patient. She is kindly agreed to help us with that, so very grateful. So first of all, we're putting our probe in the midline and we're checking the presentation. We have the baby as phallic presentation. You can see here that the placenta is low in position because that's the mother's bladder and that's her cervix. So the lower edge of the placenta, as you can see, is close to the cervix, and the upper edge of the placenta ends about the middle of the uterus with the fundus completely free of placenta. And then we check for the amniotic fluid around the fetus. So we have a decent amount of amniotic fluid, as you can see. We divide that into 4 compartments, one on the top right, left, one on the top right. See all that is amniotic fluid, one on the bottom left, and one on the bottom right. And as you can see here, that's the total insertion to that low placenta. So this confirms our diagnosis of having a low placenta at this stage. The next step is we will do a Tract Doppler at that point. So that's the cervix here. We'll be putting the color Doppler close to the cervix, and we'll be moving to the sides of the pelvis where we can then see the origin of the uterine vessels going into the uterus. So you can see the uterine vessels here, and that's where I'm going to do a demo of doing a pulse Doppler on it. It has very, very low resistance, which is good. Let's do a demo again on the other uterine vessel on the other side. Or you can actually check for the uterine artery crossing above the iliac vessels. As you can see here, that's the iliac, and this little vessel is crossing on top of them. And you can see very good waveforms for the uterine. Okay, let's go through the fetal anatomy. So when we put our probes on the baby's head, we'll be checking the views where we can get the measures for the biparietal diameter and head circumference. In that context, I'm going to be doing an assessment of the fetal growth and Doppler. So first of all, I'm going to be measuring size. So I'm measuring here the biparietal diameter, the widest transverse diameter of the skull, and then measuring the head circumference, starting from the edges of the bone to the edges of the bone here. As well, at that point, as you can see, the gestation age of the baby does not agree with what the patient has mentioned, so we'll be considering changing the dates. I'll show you a bit later. But when we're doing the skull, we can actually as well measure the middle cerebral artery Doppler. You can see here that's the circle of Willis, and I'm going to be measuring. And for the ones who has been joining me for the last couple of days, I guess we all exercised on that exercise repeatedly, didn't we? The ones who joined the last couple of days, yes. did we do that exercise together?
Yes.
Excellent. So let's keep measuring the baby. So we'll be going down. That's another the stomach. And here we'll be measuring the abdominal extension. And then I'm going to be measuring the baby's femur. So if you go through the biometry of what we've done, this does not fit at all with the fact that the patient mentioned that she's 27 weeks gestation. If you look at the measurements here, all the measurements would make her about 36 weeks and a half. So with the due date of the 22nd of November. So I'm going to change her due date, and then we can assess what is the pattern of the baby's growth. So I'm going to go to her details and change her due date. It does not fit with what she mentioned about her last week. Yes, but April would get you February. You said April. Sorry, it's my mistake. I heard you as April. I'm sorry, it's the masks. So 22nd? 20th. Okay. And that would make more sense. Okay, so we'll continue the exam and assess the measures according to that. Yes, so she's 35 weeks and 6 days, and the baby's measurements agree with that to some extent, apart from she's tall, so she has a tall femur, but the baby's abdominal circumference is big, so I would be considering checking her blood glucose level. And in order for me to make my diagnosis as accurate as possible, I'm trying to measure the fetal cerebellum. So that's the back part of the brain here, the cerebellum. I'm going to try and see what size it is, just to make sure that I made an accurate assessment of her fetal. Okay, so the cerebellum agrees with her dates. So I guess we're fine, apart from having a slightly bigger stomach or abdominal circumference. And in that context, let me just check it one more time. And accordingly, if it's still high, then we'll be considering just measuring her blood glucose. Yeah, still abdominal circumference on the 95th percentile. So as I say, I would be considering just measuring or making sure that her blood glucose levels are likely to be normal. The next step for us, since she's in advanced gestational age, will be checking her umbilical anti-Doppler. So this is a group of report here, and we'll be measuring her umbilical anti-Doppler. Which seems quite good as well. Okay, and let me go through the rest of the fetal anatomy. So I'll try to get pictures of the baby's face. So we already checked the brain. We had a look at baby's putting the hands on the limbs in front of the face. So I'll do some other things and come back to that. So here we have the baby's spine, backbone. On the side, you can see the kidneys. That's one. There is the second one. We'll try to get images of the baby's heart to try and do the echoes. So, can you try to find your right hand side? Try to move to the right side. A bit more. Can you try to find more on the right side? Just trying to move the baby because it has put all the limbs in front of the chest. It's difficult to get views of the heart between them, but we can see a bit here. So you can see here, that's the four-chamber view of the heart. These are the four main chambers of the heart. On the side, you can see brain ventricular septum, the foramen valve. You can see a bit of the ascending aorta, and here is the pulmonary artery. Okay, let's go again and try and get some pictures of the baby's anatomy again. So here is the baby's face. So that's the baby's profile. You can see the nose bone. Can you see that very clear nose bone here? You can see the two eyes, and inside them you can see the lens of the eye. You can see the jaw. You can see the lips. Just trying to move the baby around because it makes both of the limbs in front of the face immediately. But here, you can see that's the baby's nose, that's the hands, that's the lips. So there's one hand in, one hand there. You can see the nose in the middle. Let's try to slide a bit around. Can you see the face clear here? Can you see the baby smiling? Can you see that now? Don't know, watch. Can you see the baby's lips? The baby moving around here. The smiles around here. Okay. With this machine, there is what we call sonorandom live technology, where you can do while you're doing the 4D live, the machine can actually move across the surface of the target, so it can get you a better visualization, because we know that the fetus will be moving all the time, and it will help to move around as the baby is moving as well, so you can get better. See the face here? So you can see this line here that's actually moving across all the time, so it can move around according to the baby's movements, according to my hand movements, so you can get you a good image. You can even adjust our light direction so you can get better visualization. And on the volumes with this touch screen, you can actually just move all over the place, all over the volume that we're handling, just by choosing the plane we want to move around and move accordingly just by touching the screen. So you can see. So you can move around all the axes, the X, Y, and Z axis accordingly. Across the image, you can have it as a full screen. So you can see that you can utilize the whole screen for your checkups and your measurements and your assessments. You can move around all the axes. You can see it from different directions. Okay. So now to go back, so we've assessed the size, we've assessed the blood flow. Let's do the final part where we can check for ductal stenosis flow. So we get the view of the abdominal circumference. And in that view, we'll be looking for where the umbilical vein is. We know that it bifurcates into two branches. One branch would join the liver, another branch would be continuing further to join the inferior vertebra. If we put color Doppler in that region here, and we follow where the course of the umbilical vein, that's the course of the umbilical vein. It gives a branch into the liver, so the baby is moving, so I'm just trying to wait for the baby to settle down. So the branch going into the liver, and then there will be a continuation branch here, which is the Doppler. That one. baby moved, so I'm going to do it one more time. If you can see, it has 3 waves. It has 2 systolic waves and 1 diastolic wave. So what's called SE, and we're very interested in this diastolic wave, and can actually measure and trace the pulsatility index to assess the pattern of it. So once we finish that, we need to check our report to see how we're doing. So when we measure anything, we always ask for graph, so you can actually see where you are. So you can tell by the estimated fetal weight that this fetal weight is close to the 9th percentile. And when we check, the head measurements are normal. The femur is a bit tall, but that's fine. And it's the abdominal circumference that's close to the 9th percentile, and that will tell you what you need to do in ways of assessing the group, in the sense that, and the cerebellum is normal, as you can see. So you can tell when do you really need to check for her blood sugar. Here is the distribution for the middle cerebral artery Doppler flow, the umbilical artery Doppler flow, they are both normal, as well as the ductal stenosis, which is normal. So all her Dopplers are normal. We just have one issue, that she has slightly low placenta that's 3 centimeters away from where the cervix is, and that just needs to be rechecked again at later inspection.
Yeah.
Do you have any questions?
I have a question.
I just want to talk. Can you? How many? The weight. Okay, so the baby's weight is now 3 kilos and 170 grams.
For example, for low placenta,
Yeah.
patient is having 2 previous start. So how can you differentiate if there any effect of placenta?
Well, did you have any previous cesarean?
Yeah, she's 2 previous.
Okay, well, for a placenta that's at least 3 centimeters away from the cervix, that it's nearly out of the lower uterine segment, so not really considering it. It's just the placenta previa marginalis, and those are not likely to put features of placental invasion. But let me just take one picture before we take the probe and just show you one little thing since you opened the topic, because it's a very hot topic for all of us. So my mother just going to take one step fire. When we look at the placenta, we look at different parameters. The first parameter is this parameter here, where you find there is an ecolucent space, which means there is a blood lake just behind the placenta. This is one of the features that this placenta is not added into the uterus, because it's going to block that. You can see that there is an intact uterine. You can see that the uterine wall is intact and the bladder wall is intact. And when you put color Doppler as well, that area, you'll find that it does not show hypervascularity, but normally, you should actually see that vascular plane that's present between the placenta and the uterine wall, because this is actually the area where you have the legs, where you're actually doing the vascular changes that you need. So you always should be checking that, and if it's present, that's actually a good sign. It's not hypervascular. The other feature that we're concerned about when you find lacunae, which means you find vascular spaces like this one, but there are multiple and they're inside the placenta and they show vascular communication to the surface. So she does not show any of those features. She shows intact uterine and bladder wall. She shows an intact ecolucent space under the placenta, which means there's a vascular space between the placenta and the uterine wall, which allows separation or differentiation between the two layers. And as well, she does not show lacunae, which shows surface continuation. We have one more case to do the live demo on. Are you okay? All right. You're going to quiz me. You're going to quiz me. There's some picture presentation of it. How are you doing? Are you well? Are you okay? So do you know when your last period? You don't. Sorry? Yeah, when in February? The 7th of February or the 27th of February? 27th of February? Do you remember the due date? When? Do you know the due date? Can you come down a bit in the bed? So by that, she's now 39 weeks. Can you come down a bit more to the bed? Let's look at the amount of amniotic fluid. So there isn't a lot of amniotic fluid here. And in the upper quadrants as well, I can't see much of amniotic fluid there as well. Let me do the fetal biometry. So here is the baby's skull. So I'm going to measure the baby's head measurements. I'm going to do the middle cerebral artery Doppler since I'm in that area and it's easy to do so. So that's the circle of Willis here. Go down across the mother's abdomen. And measure the femur and then come back to the abdomen because there is a problem in the abdomen here that I'm going to note. If you see here, we can see that's the thorax. And under the thorax, the abdomen is split into two parts. Part has part of the liver and abdomen here, and a significant portion of it is excluded outside the abdomen. So she has what we call exomples. And exomples taken a significant portion of the liver outside the abdomen. So instead of having one circle where I can see the stomach and I can see the liver in that view, then it's all excluded outside the fetal abdomen here. So most of the liver, as you can see here, has moved out. Instead of being in that area, has moved out to being an exomples here. And if you put color Doppler, you would actually see the muscular tree of the liver going through that exomples, as you can see. So the liver has moved out of the abdomen. And you know that because in exomples, the cord insertion will be on the top. You can see that's the cord, and it's on the top of the hernia that's coming out of the fetal abdomen. I guess that's why she's admitted, probably because the fetus needs special care at the time when it's born.
So it's a major example is containing liver and intestine, mainly stomach. And she's 39 weeks by previous due date. Obviously, if you measure the stomach, it's not an easy way to measure because your assessment will be quite low because most of your abdominal contents are already excluded outside the mother's hand. And because we have little amniotic fluid, it's really difficult to do 3D and 4D assessments of different structures because you really need the amniotic fluid to transmit your ultrasound signals. Okay. So we'll have one nice final lecture. Okay, I'm going to show you just how we can do the applications of the assessment for uterine anomalies by the ultrasound using the 2D and as well using the 3D assessments to check for that. So let's start by assessing the following. We need to appreciate, first of all, what's the standard imaging do for the female genital tract, how we can assess uterus and cervix, as well, what's the views we need to achieve in order to be measuring the uterine cavity, how we can assess the lower genital tract, and by that I mean the cervix, vagina, and when and how to treat the cases. And let's start by remembering 2 points. We have the 2 mesonephric ducts forming the kidneys and the 2 ureters that are actually joining the bladder. Behind that, we have the genital tubercles, where you have the 2 ovaries, and they are joined to the external inguinal canal through the gubernaculum, which helps to pull the ovaries down from being in a pelvic position towards the pelvis. And then you have those tubes in blue, which are the 2 Mullerian ducts that we have 1 tube on each side that actually join in the middle. And when they join, they fuse and then they get canalized. And when they get canalized, you end up having the upper 2/3 of the vagina, a cervical canal, uterine cavity, and 2 terminal ends, which form the 2 fallopian tubes. That's what happened in nature. So you can actually end up having this figure here, where you have a canalized triangular shaped uterine cavity with 2 tubal ends that have fibril ends surrounding the ovaries, and a cervical canal, and an upper 2/3 of the vagina. We know that the external genitalia and the lower 1/3 of the vagina, it comes from the genital tubercle, and they both fuse together, and by their fusion, they still canalize as well, so that you have one continual channel between the vestibule opening in the skin and the vagina reaching up to the cervix. So there's been different ways of classifying the anomalies of the uterus, and from my perspective, I would actually try to make it simple for you, in the sense that you either have your 2 Mullerian ducts fused and fused well, so you form the triangular shape of the cavity, or you have 1 Mullerian duct that does not develop and the other will try to make up slightly for it, but because it's only half of the cavity size, it will have a tubular shape in the cavity. So that's what we call unicornate uterus. Or you have the 2 Mullerian ducts not fusing at all, and each one of them will end up forming a tubular shaped cavity far away from each other because they did not fuse. And by the fact that they did not fuse, their funduses, the uterus does not actually have 1 fundus. It will have 2 funduses because they have not fused the 2. Or you have the 2 Mullerian ducts fusing together, but failing to canalize effectively. And when they do not canalize effectively, they still have 1 fundus, but they end up having uterine septum. septums. And the easiest way to look at it is actually in those diagrams here. So you either have a uterus that's more or less filled, but did not canalize completely, so it has a heart-shaped appearance, or it fused, but still did not canalize significantly, so it has a septum, like this one. Or one only formed, so you have a tubular cavity in unicornate uteruses, or the two Mullerian ducts not fusing at all, so you have each fundus completely separate from the other. So when we were describing the hands-on, when we were doing the training, the last couple of days, the ones who remember with me, we always had to demonstrate a view when we can insert our vaginal probe longitudinally and get a longitudinal section of the uterus when we can see the canal of the uterus from the cervical canal up to the endometrial cavity. So you can see one continuous line from the cervix up to the fundus of the uterus. And when you move in a transverse section on that, you find that the endometrium is lying in the middle of the uterus, surrounded by the muscular. And that endometrium is one block, it does not split. But in cases when, and that wave and that endometrium will change according to where you are in the cycle. So in the follicular phase of the cycle, it will have a lot of fluid under the effect of estrogen. So it will have the triple line appearance, as you can see in this picture here, or under the effect of progesterone, it will adapt more fat, more cholesterol, so it will be more white and more echogenic. So in cases when we have unicornate uterus, we appreciated that we only have one Mullerian duct developing and the other is atrophic. And for that case, the uterus, when you do the 2D ultrasound, you'll feel that it seems slightly smaller than what it should, but it still have the globular appearance by 2D. But when you do 3D assessment of the cavity, you'll find that instead of having the triangular shaped cavity, you have a tube. Can you see that tube here? So it's a tubular kind of cavity simply because it did not develop the Mullerian duct completely. So you only have one half of the uterine cavity. One more tick in that, in making a diagnosis of being a unicornate uterus, is that the ovary is always attached to the uterus by the ovarian ligament. The ovarian ligament is connected to the back part of the uterus at that point, at the region of the fundus. So if one Mullerian duct does not develop, then that ovary would not be attached to the fundus of the uterus as it should. So when you're doing your ultrasound, you'll find that one ovary is in its normal position, close to where the fundus of the uterus is, and the other ovary is actually quite far away at the lateral end of the pelvis because it did not have that fine connection between it and the uterine cavity, because the Mullerian duct that will be joining that part did not develop. And then if sometimes you have that Mullerian duct developing, but it becomes atrophic in the sense that it did not develop an endometrium. So you end up having a horn that has an endometrium in the middle and another horn that is not canalized and does not show an endometrium inside. Do you want me to move a little bit so you can see better? But as we said before, the main issue to help to tell you what sort of Mullerian abnormality you're facing is, do we have one fundus of the uterus and has it fused or not? Which means, have both Mullerian ducts fused? And if you can see here, that's a uterus with an endometrium, another uterus with an endometrium, and there is a lot of separating tissue between them, which means the two funduses did not join each other at all. So this is the case of bicornate uterus. Bicornate means surrounding the endometrium from all aspects, but part of the endometrium has grown to split or separate the endometrial line. When we do 3D ultrasound, it's actually quite easy to demonstrate. So if you can see here, the fundus is one, but there is a tissue of muscle that's going down to separate between the endometrium. So that's the endometrium on one side, that's the endometrium on one side. Instead of being a triangular cavity, you find that the septum is splitting it here, as you can see. Can you see that septum going in and splitting the endometrium clearly? And as well, when we move to transverse sections, you will find that the fundus is one fundus, one intact fundus, but the muscular component has actually split between the two endometrial aspects of the cavity. Sometimes that septum is quite long, so it can involve just the fundus of or the whole uterine cavity, and as well it can sometimes involve, as you can see here, it's involving all of the uterine cavity. And it can even go down and split the cervix, so that's the cervical canal, and even split the two vagina, which means that the canalization did not happen properly, although they started the fusion. So you end up having uterine septum, cervical septum, and a longitudinal vaginal septum taking the upper 2/3 of the vagina. This is how it looks like. This is the uterine septum on hysteroscopy. This is the fundus on laparoscope, so it's one fundus, and this is the vaginal septum on Gynoscopic examination. As you can see here, you have one fundus, and you have a septum that's splitting the cavity into two. And you can see there's a gestational sac on one side, but still you have one uterine fundus at the end. Is it easy to appreciate that? So if we move from uterine assessment by cutting a longitudinal section, as we've done yesterday in the training, and moving again to a transverse section, we can assess whether we have one fundus or two. And if we have two, then it's a bicornate, and that's an easy diagnosis. Or we have one uterine fundus that's actually divided into two by a muscular, which was what happens in cases of uterine septums. Why are we so keen on describing that? Because uterine septums are a cause of miscarriage, are a cause of recurrent pregnancy loss, and they are easy to handle. We can actually split the uterine septums easily, if need be, by going through hysteroscopic surgery, going from the cervix, seeing where the fundus is, and using a stethoscope, we can, or scissors, or whatever instruments you have, you can split that separating tissue between the two endometrium and revert the cavity back to being as normal as possible. The minor forms of malunion would be the cases where we have arcuate uterus, when you have a little bit of an indentation in the fundus of the uterus, which gives the cavity what we call a heart-shaped cavity. Usually arcuate uteruses do not need interventions, they do not cause much of a concern, and they do not affect the patient clinically this much, but it's just a finding that you see on ultrasound. So can you see this bicornate uterus here? So you have one fundus facing this way, another fundus facing that way, and it's completely separated from each other. And sometimes we face certain conditions which affect not just the cavity of the uterus and not just the cervix, but affects as well the vagina. And one famous syndrome is called Werner-Wanderlich syndrome. And it's actually not very rare, because I see quite a lot of those when I'm doing the assessments. You have a bicornate uterus, you have two vaginal canals, but one vaginal canal is terminally occluded and the other vagina is patent, causing the menstruation. So when the girl starts her puberty, she'll menstruate through the patent one, but the obscured one will cause severe pain. It will cause accumulation of the blood in the vagina, causing hematocolpus, and in the uterus, causing hematometra, and it will present by severe dysmenorrhea, which lasts throughout the menstrual cycle. And if you can see here, you have this vagina blocked in the diagram, but the other vagina is patent, and this gives us the opportunity to correct it. This is how it looked like on ultrasound. Vagina is distended with fluid, and it's easy to correct. So we go in with the hysteroscope, even if she's a virgin at the age of 13, 14, and you can see here we have one distended vaginal cavity, okay? And that's the cervix of the normal vagina. So I'll go at the region of the cervix, and I'll do a cut at the level of the vagina until I open that septum, splitting between the two vaginas, allowing for the drainage. So I'll start doing an elliptical incision here into that distended vagina until I open it up. And then I will continue my resection so that I open the complete vaginal wall between the patent and the occluded one. So, here. So I've started opening the occluded vagina here. You can see I've reached another hollow cavity behind me, and you can see there's some leakage of blood that comes out of it. So I'll start completing the resection of that vaginal wall that's been occluded. So I end up opening the occluded and the patent vagina together on one opening, going through the vestibule, and this will correct the condition. One famous issue with those cases is that they usually have absent kidney at the site when they have the occluded vagina. So always when you look at Mullerian anomalies, just put an ultrasound on her abdomen and look at her kidneys. If you find an absent kidney, then it's quite diagnostic of this condition called Hernandez Syndrome. The problem is people would say, okay, she's a virgin, she's 13, 14 years old. Let's do it by abdominal incisions. Obviously, it becomes catastrophic because the lesion is quite low in the pelvis, you can't access it. So this is where the other vagina was. You can see the tissues are unhealthy because it has been accumulating a lot of blood and a lot of fibrin products, as you can see here. But once you open that condition, it's unlikely to recur, particularly that we try to do not just an incision, but we try to do an elliptical incision. So we take a piece of tissue out, and this is fiber. The vagina does have quite a bit of muscular component, so it recedes. And when it recedes, it's unlikely to close. But obviously, the more early in age we do them, there is a small chance that the vagina would heal again and close, and we might need to do it again at later gestation. But I've followed up some of those cases. I've seen them, and we can see them even at later gestations. I've seen some of them getting pregnant and delivering at 37, 38 weeks. So let's conclude. We can assess the uterine cavity quite clearly by doing the transvaginal ultrasound in the 2D planes, and obviously adding the 3D ultrasound can give us a significant impact because to understand the whole shape of the uterine cavity. With the new machines, we have a new technology called uterine trace, where you can actually, while doing the 2D ultrasound, you can just draw the line of the endometrium, because even if you have curves in the endometrium, if you draw a line across the uterus, it will give you a very good assessment of the shape of the uterine cavity by 3D ultrasound, starting from the cervix up to the frontis of the uterus. Always when you see anomalies that affect the female genital tract, look at the mother's kidney, the fetal kidney, the mother's kidneys, because when you have absent kidneys, it can actually provoke the diagnosis of Hernandez syndrome. Do you have any questions? Any questions?
Thanks all for your time for the last 3 days. It was a pleasure to be with you. Thanks to Ahmad El-Sheikhah for your effort for 3 days. It was fantastic. Thanks for the passion that you're showing. What you are trying to do in these 3 days to show you what's the meaning of partnership with GE and Alcan, is how we are focusing not only for the products to give you the best product to improve your skills on it or improve the patient life. Actually, you are focusing on how you learn, how you can gain, how you improve your skills that you have. We're starting the same cooperation together in Cairo 15 years ago, I think. We started like this with simple courses. Then the cooperation at Cairo develops to different phases. Now the fetal medicine unit, they're able to train more than 30 attendees per year. And we have no more than 13 or 17 fetal medicine units around Egypt now. And our cooperation with Cairo is enlarged to a next level. Now we have the first research center in Africa at Egypt that can use the machine with expertise like Dr. Ahmad Zakaria to develop some softwares and features that they can be used in the next generation of the machines. So not only for you are caring for the patients, not only for training new attendees, new doctors. Now they are developing the features. I'm very appreciative that he would with us in this 3 days. And I thank my team at GE and Alcan, and hopefully we can meet again next time. Thank you for all the attendees online. Thanks for your time, and hopefully see you soon. Thank you.
Yeah.